Hello, my name is Struycken, and today I'm presenting clinical and dosimetric implications of three-dimensional lung shunt fraction calculation using SPECT. These are my disclosures. Planar scintigraphy is used for quantification of hepatopulmonary shunting to calculate a lung shunt fraction prior to treatment with hepatic radioembolization. SPECT is acquired after MAA injection to qualitatively assess the distribution of embolic and for general treatment planning. Prior studies have demonstrated that planar scintigraphy routinely overestimates the lung shunt fraction when compared to quantitative assessment using SPECT data. However, nearly all of the patients in these studies have already low planar lung shunt fractions, often less than 5%, which is likely to be clinically irrelevant. Therefore, the clinical and dosimetric impact of lung shunt fraction overestimation by planar scintigraphy is unknown. The purpose of our study is to compare the lung shunt fraction values calculated from planar scintigraphy and SPECT in patients with high planar lung shunt fractions or an LSF greater than 15%, then to describe the clinical and dosimetric implications of SPECT use. We retrospectively reviewed all planar scintigrams obtained prior to radioembolization from 2015 to 2020 at a single institution. We included all cases with a planar lung shunt fraction greater than 50%, and which included concurrent SPECT images. We had a total of 51 cases meeting these criteria, belonging to 36 different patients. 81% of the patients were male, 29 of the patients had HCC as their primary liver lesion, and the right hepatic artery was the most common target in 35 out of the total 51 cases. The planar lung shunt fraction was calculated according to standard clinical protocol using the geometric mean of the photon counts from regions of interest drawn around the lung and liver in anterior and posterior projections as depicted in Figure 1A, and using the standard formula. The SPECT lung shunt fraction was calculated through quantitative assessment of the SPECT data, specifically semi-automated segmentation software of the liver and lung parenchyma was used to generate volumes of interest. These VOIs were then manually modified by the authors to increase accuracy, for instance, including a 1 to 2 centimeter exclusion region above the right hepatic dome to correct for respiratory motion. The mean planar and SPECT lung shunt fractions were compared using t-tests. Subgroup analysis was then performed comparing differences in shunt fraction overestimation, or the degree of discrepancy attributable to differences in patient sex, lung volume, weight, height, body surface area, target vessel, and liver lesion type. Of note, lung volumes were obtained from these SPECT images. To evaluate the dosimetric implications, the prescribed radiation doses were obtained from patient-written directives. Perfused tissue dose and lung dose using the planar and SPECT LSF was then calculated using a MERD model in the DAVR application. Of note, tumor to background liver activity, or the T to N ratio, was assumed to be 1 to simulate dose to overall perfused tissue volume. Once again, subgroup analysis was performed to evaluate the degree of discrepancy in perfused lung and tissue dose related to patient sex, BMI, etc. In 36 patients with 51 planar scintigrams demonstrating planar LSF greater than 15%, it was found that planar scintigraphy overestimated the lung shunt fraction by up to 52%. Of the 51 planar scintigrams, 29 were followed by some form of radioembolic treatment. 7 of the treated patients underwent dose reduction due to having a planar LSF greater than 15%. Of these, 6 would have qualified for an increased dose had SPECT LSF been used. 14 patients did not undergo subsequent radioembolization, or they underwent a shunt reduction procedure due to planar LSF value greater than 20%. 5 of these patients had SPECT LSF values less than 20% and would have qualified for some form of initial radioembolization. Nearly a third of patients had some form of unnecessary reduction in the prescribed dose or underwent unnecessary dose reduction procedure due to planar LSF overestimation. For all 51 cases, mean planar LSF was 29.6% and the mean SPECT LSF was 19.5%. Planar LSF was significantly overestimated in all sites and across all individual subgroups. Subgroup analysis demonstrated that there's a significant degree of overestimation or absolute discrepancy in patients weighing more than 75 kilograms with a body surface area greater than 1.9 and with left hepatic artery injections. For the 29 cases that were followed by some form of radioembolization, LSF calculated from planar scintigraphy results in significant overestimation of lung dose and subsequently underestimates the perfused tissue dose. This was appreciated in all sites and across all individual subgroups. Subgroup analysis of dosimetry data shows that lung dose is significantly overestimated in men, patients weighing greater than 75 kilograms, patients taller than 175 centimeters, patients with a BSA greater than 1.9, and patients with left hepatic artery injections. So what does this all mean? Well, certain anatomic and technical factors should be considered when thinking about these differences. For starters, there's a clear overlap of the liver dome and lung bases and AP and PA projections. Additionally, scatter from MAA activity from the liver, especially lesions near the dome, likely get included in the lung ROIs. Subgroup analysis offers additional insights into patient and technical factors. As previously mentioned, LSF was overestimated to a more significant degree in heavier patients and patients with above average body surface area, and in patients who had the left hepatic lobe targeted. Also, more photon attenuation occurs in the abdomen compared to the lungs. The discrepancy in abdominal photon attenuation compared to lung photon attenuation is exacerbated in larger patients because patients weighing more presumably have a greater relative increase of an abdominal girth versus thoracic girth. Also, the left lobe of the liver is more centrally located within the abdomen, thus likely resulting in more attenuation of liver activity compared to the lungs. Our results have clinical significance when recognizing that specific dose thresholds are considered for optimal treatment. For example, to reach the optimal 205 gray threshold of perfused tissue dose, as established by the Dosimetric trial, the mean dose activity administered would need to be increased by 2.4 times in order to be considered optimal. This would result in 49.9 gray lung dose, which is well above the highest acceptable threshold for lung activity at 30 gray. Conversely, dosimetric calculations from SPECT only required the mean dose activity administered to be increased by 2.2 times in order to be considered optimal. Additionally, this resulted in mean total lung dose of 28.6, which falls below that lung activity threshold of 30 gray. So in conclusion, SPECT has important clinical and dosimetric implications when measuring lung shunt fraction. And as personalized dosimetry continues to be refined, SPECT should be used for LSF calculation, particularly in patients with high planar lung shunt fractions, and particularly in patients, larger patients and left lobe injections. Thank you so much.